Assalamu alaikum. Welcome, students. So, as usual, before starting my class, I just want to remind you why my videos are important. There are two things. My videos are very concise, exam oriented. And if you go through them, you can write the exam either short notes or essay questions, and even they are helpful for your PG entrance. Second thing is I'm covering only one topic in each video. So if you want to see particular topic, you can just see that video of your interest without searching a lot or without wasting your time. So to start, I have one small case today. Uh, Sometimes it is asked as a short notes in your final exam, not very frequently. And second, but it is clinically very important because it is very disturbing to the patients and it takes long time for recovery. And second thing is it is very challenging for the doctors who are treating the patients. So to start with, I have 40-year-old male patient who has history of Colles fracture. The patient had history of Colles fracture, uh, and patient was treated conservatively by application of cast for 5 weeks. So nobody operated and patient was just managed conservatively. But after removal of cast after 5 weeks, the patient has stiffness in the fingers and the wrist and the hand, and also swelling around the fingers, along with the redness along the skin with hyperesthesia and sweating. So this is the clinical picture of this one. Patient had fracture of the radius, which was managed conservatively without any intervention from the surgical side. Then after removal of the cast, patient had redness, swelling, stiffness, sweating, all these things. So the autonomic system and the motor system after the fracture, uh, this is a typical presentation of patient who had Sudeck's dystrophy. So Sudeck is name of the clinician who described this one, Paul Sudeck. So to start, how will you define Sudeck's dystrophy? So it is a disorder characterized by the pain. This is pain is not related to the fracture. This pain is happening after 4 or 5 weeks of the fracture. Swelling of the involved limb, then limited range of the movement of the joints in and around the fracture with vasomotor instability. Vasomotor instability means the temperature, it disturbed color and change in the sweating pattern of the particular limb. With the skin changes, this is causing severe functional impairment to the patient because there is loss of movement, there is stiffness, and always patient is having pain. So it may disturb sleep and all. So it may be called by different names. One is reflex sympathetic dystrophy. It is the old name, otherwise called causalgia or oligodystrophy. This is the new terminology now entered in the book, that is CRPS. Complex regional pain syndrome. So what is complex regional pain syndrome? So this is actually complex regional pain syndrome is a group of disorder in which they have autonomic and pseudomotor disturbances along the limb after the injury. So this injury may associated with fracture or any other injury, but the important thing here association is association of injury to the nerve, direct injury to the nerve or no injury to the nerve, no injury to the nerve, to nerve. A direct injury to the nerve means if there is a median nerve cut injury, radial nerve cut injury, all these things, if they are having associated these symptoms after the recovery, they are called as CRPS, complex regional pain syndrome 2, where there is no injury just after any other than the nerve injury, like blunt injury to the hand or after the surgery over the hand or after the fracture of the hand. If patient is having these symptoms, that is called as complex regional pain syndrome 1. So 1, no associated nerve injury, whereas 2, there is associated nerve injury. So hope I am clear in this one. So just 2, we have nerve injury. In CRPS 1, there is no injury to the nerve. So how is the presentation? So what is the etiology behind this all this thing? So it's a exaggerated physiological response of the body after the fracture or after the injury. So what is happening here is the sympathetic activity is increased. So the increased sympathetic activity is again acting negatively over the damaged area. So this is how visual cycle goes on. So there is injury to the limb. So this starts a cycle and send the impulses to the brain. Brain send the impulses to increase the sympathetic activity by vasoconstriction and all the vasculopathy. That again affect the limb and present with the symptoms of Sudeck's dystrophy. So we have, what are the symptoms? Pain is the important symptoms here. So it associated with CRPS1 and CRPS2, complex regional pain syndrome 1 and 2. We have vasomotor system due to involvement of vessels. So there is shrinkage of the vessels, it results in coldness and change in the color to the dark color. Then there is swelling and warmth over the involved limb. Then pseudomotor, there is either increase or decrease in the pseudomotor activity resulting in hyper or hypohidrosis, and skin will become atrophy with the brittle nail and the dryness of the hand. Whereas increase in the pain sensitivity resulting in paresthesias, hyperesthesia, and allodynia. Always patient will be complaining of the pain. And due to the motor involvement, there is loss of tone and atrophy of the muscles. So patient will either have vascular symptoms or pseudomotor system due to the involvement of the autonomic nervous system affecting the sweating, or it may be direct involvement of the nerve tissue resulting in hyperesthesia, or involvement is of the motor tissue resulting in weakness of the limb. So how will you diagnose it one? So we do X-ray. So basically it is a clinical diagnosis, but for confirmation, you can take the X-ray. So X-ray will show osteopenia. Here you can see comparison of the normal bone here and the patient who is having Sudeck's dystrophy. Sudeck's dystrophy, if you see, there is complete osteopenia of the carpal bones. Then there is subperiosteal bone resorption. So this is the periosteum. Here is the normal bone. Here, this all is blackened out. So it is resorption of the periosteal bone. The important here thing is preservation of joint spaces. This is how you differentiate from rheumatoid pathology. In rheumatoid arthritis and all, there is destruction of the joint lines. I mean, articular cartilage will destructed, whereas in patient who is having Sudeck's dystrophy, the joint line is well maintained, but there is osteopenia and there is subperiosteal bone resorption. One more confirmatory test to check the increased blood flow to the limb is triphasic bone scan. If you take the bone scan, you can find increase in the blood flow and increase or intensive uptake of delayed blood pool. So here, if you see, this is the X-ray of, this is the bone scan or picture of involved limb. This is normal side. You can see increase in the flow of the blood here. So once you have diagnosed, how will you treat? So the treatment, it is just time taking. So sometimes it improves in 3 to 4 months. Sometimes it takes a year to improve, but patient needs some supportive treatment. So we can give NSAIDs. Patient should advise physiotherapy because there is stiffness. So you need to keep on moving the joints to prevent the development of permanent contracture. Vitamin C, high dose of vitamin C known to decrease the chances of patient developing reflex sympathetic dystrophy. So it's can be given when prophylactically also. Patient who are at risk of developing this one, you can give prophylactically. So it can be given to all the patients who are presenting with the fractures. Then bisphosphonate. What is the role of bisphosphonate? They decreases the absorption of the bone. So they are responsible for decreasing the bone resorption. So density is improved if we give bisphosphonate to the patients who are having reflex sympathetic dystrophy. Beta blockers like propranolol and all to decrease the sympathetic activity because they are sympathetolytic drug. So thanks to my birds, they are nice listeners. So it was very difficult to present without any audience. So I am presenting in front of my birds. So you can hear the voices of my birds responding to me. Then tricyclic antidepressant. They are also centrally acting sympathetolytic drug. So the sympathetic, like then you can give symptomatically patient is having burning or something like that, pregabalin. So I prefer to give 3 drugs. So one is propranolol, And I mean, the response to this is very good. If I propranolol, vitamin C, and some tricyclic antidepressant I give. So for longer time, and all three are safe drugs. We can give for months together. Whereas NSAIDs and pregabalin cause dependence, NSAIDs, renal and gastrotoxicity, and bisphosphonates also not safe all the time. So we can give all these medications. If patient is not responding, very disturbed due to this one in the form of disturbed sleep and all, we can do surgical sympathectomy. So we can stellate ganglion or this one, either we can block it surgically or by doing some chemical injection. So surgical sympathectomy is the treatment if patient is not at all responding and it is disturbing the patient completely. How you need to keep in the mind two more things as a differential diagnosis. One is rheumatoid arthritis. As I told, rheumatoid arthritis, there is destruction of the joint. Second thing is it is involving bilateral limb, bilateral and symmetrical most of the time. So whereas reflex sympathetic dystrophy only affect the joint which got fractured. Second is Raynaud disease or Raynaud phenomenon. This is due to vasospasm of some unknown origin with there is necrosis of the tip and bluish discoloration. This we won't find in patient who have reflex sympathetic dystrophy. This is all about my topic today. So just to remind you, reflex sympathetic dystrophy is happening after the fracture. The pathology behind is increase in the vascular autonomic activity due to unknown reason. Patient is having either motor system involvement or patient is having autonomic involvement or involvement of the sweat gland activity or pseudomotor activity is disturbed here. You will diagnose it by X-ray, and the special feature is there is no arthritis, only there is osteopenia and bone resorption. And bone scan is confirmation, one more important diagnostic tool for the patient who is having suspected reflex sympathetic dystrophy. Treatment is having multiple treatment options, beta blockers, vitamin C and tricyclic antidepressant holds good as a treatment part, and non-responding cases, they need surgical sympathectomy. And you need to differentiate from rheumatoid arthritis or Raynaud's phenomenon and Raynaud's disease. And complex regional pain syndrome 1, there is no associated nerve injury, whereas complex regional pain syndrome 2, there is associated nerve injury. Thank you. Please like, subscribe, and share the videos with your friends. Thank you. See you in next time.